discussed about 10 questions related to pediatrics, and in these scenarios the frequently asked ones were NICU, NRP, resuscitation, some neurological pointers, Pete's neuro pointers, some common scenarios like breath holding spells, some typical syndromes like Tourette syndrome, right? So let me know if the video and audio is fine. If fine, then we can go ahead. Okay, so let's start now. Uh, so we are going to discuss 10 questions. Okay, so without any further ado, let's start. So for the first question, we'll go in the same pattern. We'll look at the video, we'll look at the question and try to answer it. Okay, so let's start with the first video. Look at this. Look at this video. What can you notice over here? Can you notice something is moving in the abdomen of this child? Something is moving. What is this movement? Can you notice? Can you notice this mass, olive shaped mass that's moving? Can you notice the movement happening? Right? So this is a visible peristalsis happening from left to right direction, and this is an olive shaped mass. This child presented to us with episodes of recurrent vomiting, and this child landed up with severe dehydration in your emergency. And on examination, you notice this, an olive shaped mass moving from the left side to the right side. That is a visible peristalsis you can notice, right? So let's see what the examiner is trying to ask us. So examiner is asking which of the following ultrasonographic findings is diagnostic in this infant's condition. The first option is intussusception telescope appearance with target sign, pyloric muscle thickness more than 4 mm and channel length more than 16 mm, whirlpool sign of superior mesenteric artery, or duodenal double bubble sign. What is this? Yes, so Sheil is right, Gurjeet is right. This is nothing but hypertrophic pyloric stenosis, right? Congenital hypertrophic pyloric stenosis. And what is the ultrasonographic finding over here? It's this, right? It's this, it's B. That is that the thickness of the pyloric end would be more than 4 mm and length more than 16 mm. Right, where do you see this telescope target sign in intussusception? Here you will present, the patient will present with current jelly stools, right? A pain abdomen. Whirlpool sign you see in midgut volvulus. Again, duodenal double bubble we will see in cases of duodenal obstruction. That could be due to duodenal atresia, could be duodenal web, stenosis. So let's learn and revise about this congenital hypertrophic pyloric stenosis. So a condition which is frequently seen in firstborn male children. Firstborn male children. What happens over here? The name itself asks congenital hypertrophic pyloric stenosis, also known as idiopathic hypertrophic pyloric stenosis. So there is hypertrophic of the pyloric end, specifically the circular muscles at the pyloric end. So what will happen? Because of this hypertrophy at the pyloric end, the gastric outlet will be obstructed. So whatever the child is eating would come out in the form of vomiting, and there is projectile vomiting. This vomiting would be bilious or non-bilious. Bile is secreted down here into the duodenum. So this will be non-bilious vomiting, usually happens after 2 to 3 years of life. And the characteristic finding that you note on examination that we just saw in the video is there is a visible gastric mass, an olive shaped mass that moves with peristalsis left to right. right? On ultrasound, you notice pyloric thickness is increased more than 4 mm and length more than 16 mm. Apart from that, if you go for gastric meal, then you will see string sign, mushroom sign. Because of this recurrent vomiting, these children usually present with the dehydration, hyponatremia, and because of this loss of gastric acid, there will be metabolic alkalosis. Acid is getting lost from my body. So whenever acid is getting lost from my body should try to conserve acid. But on the other hand, here my body will excrete acid. There will be paradoxical aciduria. Why this happens? Because of this dehydration, hyponatremia, my RAS system gets activated, and we all know when RAS gets activated, there is conservation of the sodium and excretion of H plus and K plus, right? So the picture that we see over here is hypochloremic metabolic alkalosis with paradoxical aciduria. The management here is simple. Firstly, emergency management, you do dehydration correction, electrolyte imbalance correction, and finally definitive thing would be surgery. We do Ramsted's pyloromyotomy, right? So this is about congenital hypertrophic pyloric stenosis. Let's move to the next question now. So next video, look at this video. What is happening over here? Examiner is turning the head of the child to one side, and what can you notice? What can you notice over here? Notice what is happening. Examiner is turning the child's head to the one side, and what is happening? Did you notice the limbs? Limbs on the side to which the head is turned undergo extension, and the other side undergo flexion, right? So I hope you all got what was this. So the examiner is asking about ATNR. Let's see the question stem. During a routine developmental assessment of a 3-month-old infant, the pediatrician turns the infant's head to the left side while supine. What is the clinical significance of this finding? Option A says that this is a normal developmental finding that is expected up to 6 months. Option B says it's a marker of upper motor neuron pathology that like CP. Option C says this is an early feature of spinal muscular atrophy, and option D says it is a pathognomic sign of congenital brachial plexus injury. So it is a 3-month infant in which you see this reflex. This reflex is nothing but asymmetric tonic neck reflex. What happens in asymmetric tonic neck reflex? What did you see over here? Asymmetric tonic neck reflex, also known as fencing reflex. Fencing. Have you seen that sport? Fencing. That stick like sword fencing, right? So what happens over here? Can you notice? The side to which the infant's head is turned, on that side there is extension of the upper limb and the lower limb, and on the other side there is flexion, as if the child is holding a bow and arrow, right? So if you are aiming with a bow and arrow, your posture would be somewhat like this. So this is nothing but asymmetric tonic neck reflex. This appears around 35 weeks of gestation, and it disappears when the child learns to roll over. So that's around 4 to 6 months of age. So the appropriate answer here would be that this is a normal developmental finding that is expected up to 6 months of age. If on the other hand, here the infant was not 3 months, it was say 8 months. So that means there is persistence of this neonatal reflex. That means there is some problem in the neurodevelopment. So in that case, the answer would have been that this is a marker of upper motor neuron pathology. In spinal muscular atrophy, the stone is lost. So you will see a very floppy bacha. And in congenital brachial plexus injury, in fact, on one side you will see the decreased movements or paucity of movements, which is not noted over here in this video. So the correct answer, you all are right. This is nothing but ATNR, and option A is correct. Right? So neonatal reflexes are very important for your exam, and expect one of the questions, video-based questions, most probably from out of these. So moving to the next question, this is again a neonatal reflex. Look at this. This is a newborn, and what is this? What is this? Sudden dropping of this child produced this reflex. right? What is this reflex? So this newborn is undergoing neurological examination. Which of the following clinical scenario represents a pathological absence of this reflex bilaterally at this age? First of all, what is this reflex? I hope you all know this is nothing but the very famous Moro's reflex, right? So the examiner is asking in which of these conditions this reflex would be absent bilaterally. So the first option is an infant with gestational age of 39 weeks weighing 3.2 kgs. This is an absolutely normal bacha, a term bacha, normal birth weight bacha. So here in this case, Moro's reflex would be normal. Why would it be absent? So omit this option. Second says severe hypoxic ischemic encephalopathy or profound brain injury. This could be a correct answer because I know that in severe hypoxic encephalopathy, the reflexes are absent. Option C says mild hyperbilirubinemia and mild hyperbil condition undergoing phototherapy. So mild jaundice won't cause this neurological dysfunction. So omit this. And last says benign neonatal sleep myoclonus. The name itself says it is a benign condition in which the child has myoclonic jerks while sleeping, and it is a benign condition. It resolves on its own. So again, no relationship with this abnormal finding. So the most appropriate answer here is B. Everyone here is right. The answer is B. Severe HI. So let's learn and revise again about this Moro's reflex. So firstly, they ask what is the components of Moro's reflex. So remember, this is also known as embrace reflex, as if you are hugging someone, right? So there is extension, abduction, flexion, adduction. Sometimes the fifth component, that is cry, is also included. Examiner is particularly fond of asking abnormalities of the Moro's reflex. This reflex can be absent, as we saw earlier. This could be an asymmetric reflex. It could persist for a longer time, as in CP, right? And it could be unilateral. So let's see, absent, we discussed HI3, severe HI, or in cases of cortical malformation. What about asymmetric Moro's? Asymmetric Moro's means normally this is happening, right? Asymmetric Moro's means one side is only doing this, the other side is not doing this reflex. So when this will happen, why the other side is not moving? It could be some neurological problem or it could be some skeletal problem. So neurological problem, we know upper limb is supplied by the brachial plexus. So if there is any brachial plexus injury, there will be asymmetric Moro's. Second, if there is clavicular flexion or shoulder dislocation, any trauma during the surgery, again there will be asymmetric Moro's. Persistence of neonatal reflexes, I told you, are indicative of immature brain developmental halt, indicative of cerebral palsy. And lastly, very important, exaggerated Moro's. When will you see exaggerated Moro's? Remember HI1, that is the mild hypoxic ischemic encephalopathy, and hypoglycemia, you see this exaggerated Moro's, right? So this is an important table regarding abnormal Moro's reflex. Let's move to the next question. Question number 4. So look at this. Nursing staff is trying to give feeding to this child, and because this child is just 28 weeker, we are giving OG feeding, right? Can you see how did this nursing in charge put the OG tube, right? So this is a video showing OG tube insertion. So let's see what the examiner is asking us. So examiner is asking that a nursing instructor demonstrates the insertion of orogastric tube in a preterm neonate. What is the correct landmark of sequence used to estimate the insertion of length of an OG tube in a neonate? This question INI people used to drop left, right and center, and few times in NEET PG they have also asked. So what is the correct landmark? That means they are asking how do you measure, at what point you have to fix the tube? How do you measure the length of insertion, the depth of insertion of this OG tube? Option A says mouth to earlobe to the midpoint between xiphoid process and umbilicus. Option B says nose to earlobe to the midpoint between xiphoid and umbilicus. Option C says tragus of the ear to the sternal notch to the umbilicus, and option D says mouth to the xiphoid process directly. So if you look at, okay, so if you look at this insertion video given by AIMS people, so they have given firstly how to decide the size. If the child is less than 2 kgs, go for 5 French size. After that, go for 6 French size. And you measure from nose to earlobe to the midpoint between xiphoid and umbilicus, right? So remember these two terms, nex and nemu, nex and nemu, right? N is for nose, E is for earlobe, and X is for xiphoid. And which one AIMS people give? They give NEMU, that is nose, earlobe, and mid umbilicus, right? Mid umbilicus. So these are the two methods that we follow. In AIMS, they have given this NEMU method. So prefer always and always this, right? So option B. If obviously our NEMU is not there, the second best would be next. That is nose to earlobe to xiphoid process, right? And how do you confirm the position of this tube, whether this tube is actually in its right position in the stomach or not? We take a syringe, we push gas through that syringe, right? Take a 2 ml syringe, and over the epigastrium you hear about a whoosh sound. If whoosh sound is there, the tube most probably is in the stomach. Sometimes what can happen, this tube can be a little higher up and you can still hear the whoosh. So confirmatory would be doing an x-ray, right? Sometimes taking an aspirate out and getting gastric clear gastric aspirate is also another sign that it is in the stomach, right? So this is about OG tube insertion. Now let's move to the next question. So look at this, an examination finding in a girl. So what happened? Flexion of the neck, and I can see again flexion of my thighs, right? Can you notice? Look again. Is it ringing any bells? What is this sign? So let's see what the examiner is trying to test. So examiner says that this is a 6-year-old child with high-grade fever and neck stiffness, and the child is being evaluated. When the examiner passively flexes the child's neck in the supine position, involuntary flexion of hips and knees is observed. Which reflex or physiological mechanism accounts for this positive clinical sign? So we all understand this high grade fever, neck stiffness. This is nothing but a child with meningitis, but the examiner is asking why this is happening. We all understand what is this sign, but why this sign is happening, the examiner is asking. So let's look at the option. First says that while we do this, there is radicular stretching of the inflamed spinal nerve roots causing the reflex lower lip flexion. Option B says excessive tone due to corticospinal lesion at the internal capsule. Option C says labyrinthine positioning reflex activated by cervical spine motion. And option D says spasticity secondary to lower motor neuron disinhibition. What is this? Why this reflex is happening? Very straightforward, right? Meningitis, there is inflammation, and it is this stretching of the inflamed spinal nerve root that causes this lower limb flexion. Dr. San is right, Sushdairi is right. This is nothing but Brudinsky, right? So let's revise the features of the meningitis that you see. You will see fever, you can see seizures, you will see features of raised intracranial tension like papilledema, photophobia, and once the anterior fontanelle is closed, you can see the signs of meningeal irritation, that is neck rigidity, Kernick signs, Brudinsky sign, right? So usually you get confused whether this is Kernick's, whether this is Brudinsky. So remember K for Kernick's, K for knee, right? So whenever there is like the extension over the knee, can you look over here? What is happening? The examiner is like causing extension of the leg over the thigh, extended thigh, right? And by doing this, I can notice flexion at the head end, flexion at the head end. So this is Kernick sign, K for knee, right? So whenever you are extending the knee, this is Kernick's. And what is Brudinsky? Whenever you are flexing the neck, this is Brudinsky neck sign. Another Brudinsky leg sign is also there, where you just passively raise the leg, right? And in that case, again, you see bending of the other limb. So let's see these other signs as well, the videos of these other signs as well. Notice this girl child. This is another patient. What is the sign? Passively raising and then bending. Passively raising, and then you can notice bending of the other leg. This is Brudinsky leg sign, right? And what about this? This is Kernick's, right? So if there is extension at the level of knee, this is Kernick's. This is Brudinsky leg sign, right? So this is Kernick's, and this is Brudinsky leg sign. And neck sign, you have noticed this, right? So this is about the signs that you notice in meningeal irritation, meningitis. So now let's move to the next question, a very famous one question. I believe this is the very first video that INI people dropped in their exam, and this is over their preterm baby package YouTube channel as well, right? So they gave this newborn in their NICU, right? This is a preterm child, right? Whenever you see this child and they have mentioned audible grunt, just mark 8 as the distress score, right? Because multiple times they have given this newborn, and whenever you see this face, you just tick 8, because they have not even creatively changed this question ever. The same stem comes again and again, right? So let's see what they have asked in the question. So in the question, they have given again a 28-week preterm infant with RDS who is being monitored under a radiant warmer. Grunt is easily audible with naked ear. That means 2 point. And now they have asked us to calculate the Silverman-Anderson score and what management state does it indicate. So if you look at closely at this picture, so they have given grunt, audible grunt, that is +2. Apart from that, what are the components of the score? We have upper chest retraction, lower chest retraction, xiphoid retractions, nasal flaring, and grunting. So grunting they have given is +2. If you look closely at this video, you can notice that there is seesaw movement of the chest. So there is +2. Lower chest retraction, again there is +2. +1, mild. Xiphoid is also mild. Nasal flaring is prominent, 2. So the total comes out to be 8, right? 8. 2, 2, 2, 6, 2, 8. So total is 8, right? So answer here is 8. There is severe distress and you need immediate CPAP. Right? So let's revise the Silverman-Anderson score. 5 component Silverman-Anderson score you apply for preterm babies: upper chest retraction, lower chest retraction, xiphoid retractions, nasal flaring, and grunting, right? What is easy? Lower chest retraction, xiphoid retraction, easy. If no retractions, give 0. If mild, 1. If severe, 2. Same goes for nasal flaring. No nasal flaring, 0. Mild, 1. Severe, 2. Grunting, if no grunting is there, you give 0. If grunting is only audible when you place the stethoscope over the chest of the child, that means otherwise you cannot hear, but on placing the stethoscope you can hear, 1. If you don't need a stethoscope, the grunting is so loud that you can hear it with your naked ear, then 2. Lastly comes upper chest retractions. If there is synchronous breathing, 0. If there is a lag on inspiration, 1. And if there is seesaw breathing, 2. Right? So depending upon the case scenario that the examiner has given, you give a score, and on the basis of the score you tell whether this is mild distress, moderate distress, severe distress. So if it is 0, the score comes out to be 0 to 3. 0 to 3, this is mild distress. 4 to 6 is moderate, and after 7 it is severe. So in mild distress, you just wait and watch. In moderate, you go for oxygen or CPAP therapy. And in severe, you go for mechanical ventilation. Mechanical ventilation. Right? This was about the score that we employ for preterms. Now let's look Downey score. Downey score. Right? In Downey's, remember the mnemonic GRACE. Grunting, respiratory rate, air entry, cyanosis, retractions. Grunting and retractions is same as the Silverman score. No grunting 0, audible by stethoscope 1, audible by naked ear 2. For retractions, no retraction 0, mild 1, severe 2. Respiratory rate, normal respiratory rate of a newborn is 40 to 60 breaths per minute. So if the respiratory rate is less than 60, give 0. 60 to 81, after 82. Air entry, if the air entry bilaterally is equal, 0. If the air entry is decreased, 1. If absent, 2. Lastly, cyanosis. If there is no cyanosis, 0. If the cyanosis is just on the room air, as soon as you give oxygen, the cyanosis disappears, 1. But if the cyanosis persists despite 40% of the oxygen, 2. Right? So this is Downey score. They are most probably are not going to ask about calculating the Downey score, but definitely they can ask about the components of Downey score because they have asked that multiple times in the exam, right? So they gave multiple options and asked which of these is not a component of Downey score. So remember the mnemonic GRACE, and thus you will know the components of Downey score, right? So a very important topic, a very important score in neonatology apart from the APGAR score, these two, Silverman as well as Downey score. Right, now let's move to the next question. Question number 7. Look at this child. I asked this child to stand up while he was sitting on the floor, and this is how he's standing up. Okay, so can you see how he's just climbing upon himself to stand? Right? Why this is happening and what is the sign? A very famous sign, right? A very famous one. This is nothing but Gover sign. And where do you see this Gover sign? Wherever there is proximal girdle weakness, proximal muscle weakness. And a very important prototypical example of that is Duchenne muscular dystrophy, Duchenne muscular dystrophy. So let's see what the examiner is trying to ask over here. So this is a 4-year-old boy who is brought to your pediatric OPD by his mother due to frequent falls and difficulty in keeping up with the peers at the play. That means the child is frequently falling and gets tired easily, not able to cope up while playing with the other peers. Which of the following is the most appropriate initial test for the suspected underlying condition? So by the history and by the examination, you are suspecting Duchenne muscular dystrophy. So the examiner is asking, what is the first test? What is the initial test that you want to do over here? The option A says nerve conduction velocity study. Option B, serum creatine kinase estimation. C, muscle biopsy of the vastus lateralis muscle. And option D says lumbar puncture and CSF analysis. इनिशियल टेस्ट में आप बायोप्सी कर दोगे उसकी, आएगा बच्चा और सीधा बायोप्सी, यस बायोप्सी कर दोगे सीधा ही. Remember, the initial screening test is not biopsy. Dr. San is right. It is serum creatine kinase. So initial test you do is serum CPK or serum creatine kinase, which is very much elevated in this condition, right? And definitive test would obviously be molecular testing for dystrophin gene. Right, so the correct answer here is serum creatine kinase. So what is Duchenne muscular dystrophy? I hope you all know this is an X-linked recessive condition. That means only males can have it. Females would be carriers over here. Here the mutation is in the dystrophin gene, which is on the X chromosome, petit arm of X chromosome, XP21. This dystrophin gene codes for the dystrophin protein. This dystrophin protein is very important part of my muscle membrane, that is the sarcolemmal membrane. So if it is problematic, my muscle will die, right? So if there is frame shift mutation, nonsense mutation, that means no dystrophin protein is formed, I have a condition known as Duchenne muscular dystrophy. So here the muscle cells will die very early and the child will present very much earlier, within 5 years of age. On the other hand, if there is missense mutation, that means some amount of protein is formed, I have a condition that is known as Becker's muscular dystrophy, that presents later on, will have much lesser implications because some amount of dystrophin is there, right? Here we see proximal muscle weakness, so the child is going to have waddling gait, calf pseudohypertrophy, Gover sign. Because of the laxity of the spine, there will be scoliosis. Usually onset is before 5 years of age, and usually these children die of the complications: respiratory muscle paralysis leading to respiratory insufficiency, or cardiac problems, cardiomyopathy, congestive cardiac failure. So these are the two important cause of death in these patients, right? Apart from that, very important, the initial investigation, the screening investigation will be creatine kinase, highly elevated, and the best is the molecular diagnostic testing. These are the two things that the examiner can ask. Calf pseudohypertrophy. Remember, this calf is not hypertrophied. Calf is very weak. Muscles are very weak. There is just fibrofatty deposition. That's why the calf is looking so big, right? There is pseudo hypertrophy, not true hypertrophy. And you see Gover sign, when you ask the child to stand up from the sitting position, the child will climb upon himself to stand, right? So this is Duchenne muscular dystrophy. Now let's move to the next question. Look at this child. Look at the walk of this child, how the child is walking. Can you notice how he's just crossing his legs? What type of gait is this? What type of gait is this? Crossing the legs. So crossing like a scissor. What is this? What is this gait called? Can you notice how the legs are twisting? Can you notice? Coming in front of each other. This gait is known as scissoring gait. Scissoring gait. Right? And where do you see the scissoring gait? When lower limbs are spastic, you see the scissoring gait. So you see the scissoring gait in spastic diplegia. Spastic diplegia. Right? So spastic diplegic CP, you see this gait. Let's see what the examiner is trying to ask. So the examiner is saying that we have a child with spastic diplegic cerebral palsy who presents with this gait. This child is undergoing MRI to evaluate what is the underlying etiology of this cerebral palsy. So which of the neuroimaging finding is most characteristic of spastic diplegia in a child who is born prematurely? So the examiner is basically trying to test whether you know the brain injuries, the brain injury that you see in preterms, right? So the options we have are bilateral putaminal necrosis, periventricular leukomalacia, unilateral schizencephaly, or cerebellar vermis hypoplasia. Dr. San is right. This is periventricular leukomalacia. So let's understand the brain injuries that you see in term and preterms. So firstly, the most common injury in term babies is actually perinatal asphyxia. So in perinatal asphyxia, what is happening? The name itself says asphyxia. At around the time of birth, there is asphyxia. So that means lesser oxygen is going, lesser delivery would be there to the parasagittal areas, the watershed areas. So parasagittal, you understand, sagittal is the midline, so parasagittal would be approximately this area. So that means my both upper limbs and lower limbs would be affected. I'm going to have spastic quadriplegia. On the other hand, what is the injury? Most common injury in preterms, we have intraventricular hemorrhage. Intraventricular hemorrhage, and ventricles are somewhere here in the midline. Germinal matrix, remember, around the lateral ventricles. So if that area is injured, my lower limb would be affected, not the upper limb. So I'm going to have spastic diplegia. And in future, this term baby with perinatal asphyxia will form spastic quadriplegic CP, and preterm baby spastic diplegic CP. Most common in India is spastic quadriplegia because of this parasagittal infarction, and the MRI picture that you see over here is multicystic encephalomalacia. On the other hand is spastic diplegia, you are going to see periventricular leukomalacia. So here, because only the lower limbs are involved, you see this scissoring gait along with that commando crawling when the child starts to crawl is very characteristic of this spastic diplegia, right? Okay, so now let's move to the next question. Look at this child. They have given this child. This is a child with the 3-year-old child with 3.5, say 3.5-year-old child with developmental delay comes to you, and the child is playing in the play area of your OPD, right? Can you notice some peculiar finding about this child? Does this child look normal to you? Are there any peculiar facial features that remind you of one important syndrome that you study in genetics? What is this child? Very peculiar features. This child has developmental delay in a mental retardation, and along with that, these particular faces. Any syndrome you remember? Yes, this is nothing but Down syndrome. So the examiner is asking that this 3-year-old boy, boy with developmental delay presented to your OPD, which of the hematological malignancy is this child at the highest relative risk of developing compared to the general pediatric population at this age? Options we have are AML, FABM7, ALL, CML, or Hodgkin lymphoma. So they are asking about the associations of the Down syndrome. So which of the following blood cancers, hematological malignancies is common in Down syndrome as compared to the other normal population? Look at the age of the child. This child is not a chota child, right? This child is 3-year-old. It's very important that the most common, if you look overall, is actually ALL. But in smaller children, usually less than 3 years of age, it's AML M7. So look at the age. If it is less than 3-year-old child, if they would have said 1 year, 2 year, then AML M7 would be a better answer. But here the child is 3-year-old. The correct answer here would be B, ALL, right? So let's revise the clinical features. What the most striking features in Down syndrome is hypotonia. Apart from that, the typical characteristic feature that we see in the face, there are epicanthal fold. In iris, you see brush filled spots. There is mental retardation, a mongoloid slant, that is the outer canthi point upwards, low set ears, protruding tongue. Associations include cardiac defects, endocardial cushion defects. In hands, you see Simon crease. Fifth finger is very long, fifth finger clinodectally. Intestinal atresia, anal pancreas, Hirschsprung disease, and in foot, you see sandal gap, that is a gap between the great toe and the other toes, right? The features important for your exam, the examiners ask association. Remember, these Down syndrome children have high risk of hypothyroidism, high risk of atlantoaxial dislocation, high risk of leukemias, most common being ALL, and if a child is less than 3 years of age, AML M7. Apart from that, again, high risk of conductive hearing loss and high risk of pre-senile Alzheimer's disease, because the amyloid precursor protein APP protein lies on 21 chromosome, and because they have one extra 21 chromosome, the Alzheimer's disease happens earlier. And remember, in these children, low IQ and developmental delay is universal. Okay, so this is about Down syndrome. Now let's move to the last question, our last video. Look at this child, a newborn child. Focus on the face and the hands. Can you notice the overlapping fingers? Look at the foot of the child. How the base of the foot is like curvy. What is this? Right? Look at the fingers, overlapping like this, and foot is curved. What is this? We have overlapping fingers, overlapping digits, and rocker bottom foot. Rocker bottom foot. Rocker bottom foot. Yes, this is nothing but Edward syndrome. What is Edward syndrome? This is trisomy 18. Second most common trisomy. First one is Down syndrome trisomy 21. The second most common is this Edward. So let's see what the examiner is asking. Examiner is asking that this syndromic child is evaluated for renal anomalies. Which of the specific renal structural anomalies most strongly associated in this condition? Option A says bilateral MCDK, that is multicystic dysplastic kidney. Option B says horseshoe kidney. Option C says autosomal recessive polycystic kidney disease. And option D says unilateral renal agenesis. So you all understood from the video that this is nothing but Edward syndrome. Now they're particularly asking, in Edward syndrome, which most common renal anomaly do you see? So what is the most common renal anomaly that you see in Edward syndrome? Yes, anyone? So this anomaly, the anomaly, that renal anomaly that we see, yes, Shelja is right. This Yuvraj is also right. This is horseshoe kidney, horseshoe kidney, horseshoe kidney. Mansi is also right. So let's revise Edward syndrome. E for Edward, E for 18. So this is trisomy 18. This is the second most common trisomy after Down syndrome. The typical feature that you see is elongated occiput, malformed dysplastic ear. You see overlapped fingers, clenched hands, and rocker bottom foot. Have you seen this rocking chair? So the rocking chair is very similar. The base of the rocking chair is very similar to this foot, so that's why this is known as rocker bottom foot, right? So these are the important features that you need to know: elongated occiput, overlapping digits, rocker bottom feet. These children have intellectual disability, congenital heart diseases like VSD, and renal anomalies, and the most common one is nothing but horseshoe kidney. And another MCQ that you need to know for your exam is the most common cause of death. Remember, the most common cause of death over here is apnea or respiratory failure. A very similar syndrome that the examiner can give is Patau, which is trisomy 13. So let's see how Patau is similar over here. So Patau syndrome, again, you will have this overlapping fingers, but there are multiple digits, polydactyly. Brain malformation is there, microcephaly is there, cleft lip, cleft palate is there. They also have rocker bottom foot, they also have renal anomalies, they also have VSD. So how do you not confuse these two in the exam? So remember, if the examiner gives rocker bottom foot, rocker bottom, choose Edward over Patau. And if the examiner gives the midline problems, cleft lip, cleft palate, this hollow prosencephaly, then choose Patau over Edward, right? So this, make this a thumb rule in your exam. Rocker bottom foot, choose Edward. Cleft lip, cleft palate, choose Patau. This is obviously when you have both the options. If one option is there, then you definitely choose that particular option. But if two options are there, then don't get confused. If rocker bottom foot is given in the question, it is Edward. If midline problems, cleft lip, cleft palate, hollow prosencephaly is given, go for Patau, right? रेड सिंड्रोम हमने लास्ट उसमें बहुत अच्छे से डिस्कस किया था, आप लास्ट वीडियो बेस्ड क्वेश्चन देख लो, उस पर रेड सिंड्रोम का क्वेश्चन भी और हमने पूरा डिस्कस भी किया है, न्यूरो रेग्रेशन, हैंड रिंगिंग मूवमेंट्स, MECP2, एवरीथिंग वी हैव डिस्कस्ड, राइट? So with that, we finish the 10 questions of today's video based discussion. If any doubt is there regarding any of these topics that we discuss, feel free to drop that down in the comments section. I'll be more than happy to cover that up. If not, then we can end this class. I hope this was helpful. And don't panic regarding this video based question, right? Most of you were able to answer only, right? If you know things, you are going to answer. You just have to be prepared that the examiner can throw in videos too. You don't need to get scared that what the examiner is trying to get ask you, right? You just blankly see the video, read the question stem. Mostly when you are reading the question, you will get a just what the examiner is pointing in that particular video, right? रिफ्लेक्स टाइमलाइन डॉक्टर सान हमने बहुत अच्छे से, अगर आपके पास मेन वीडियोस हैं तो इन मेन वीडियोस में रिफ्लेक्सेस, न्यूनेटल रिफ्लेक्सेस का एक सेपरेट सेक्शन है, उसमें अच्छे से सारे रिफ्लेक्सेस कब आते हैं, कब अपीयर होता है, कब डिसअपीयर होता है, कैसे एलिसिट करते हैं, क्या दिखता है उस पर्टिकुलर रिफ्लेक्स में, वो सब डिस्कस किया हुआ है। और पूरा मैंने इनैक्ट भी किया हुआ है एक डमी के साथ। तो अगर आपके पास मेन वीडियोस हैं तो डू रिविजिट दैट। एनी अदर डाउट? So this वन ऑफ द क्वेश्चन इज रिगार्डिंग एब्डोमिनल मास, वो हमने ऐसा कुछ डिस्कस किया नहीं। और पीडियाट्रिक्स पर से में ये एब्डोमिनल मासेस हम पढ़ाते भी नहीं है, बट सर्जरी में पढ़ाते हैं। थंब रूल आप याद रखो, विल्म्स ट्यूमर दोनों ही बैलेटेबल होते हैं। विल्म्स ट्यूमर एक्चुअली साइज में थोड़ा बड़ा होगा, बट पैल्पेशन पे यूजली स्मूथ होता है एंड डज नॉट क्रॉस द मिड लाइन। ऑन द अदर हैंड जो न्यूरोब्लास्टोमा है वो थोड़ा हार्ड होता है, इरेगुलर होता है, क्रॉस कर देता है मिड लाइन। और न्यूरोब्लास्टोमा में आपको और साइंस दिखेंगे मेटास्टैटिक डिसीज के, बोनिंग पेन, ट्रोपोप्टोसिस, ऑल ऑफ दीज थिंग्स वुड आल्सो बी देयर, राइट। सो सर्जरी में बहुत अच्छे से बताया होगा आपको एब्डोमिनल मासेस में, उसमें न्यूरोब्लास्टोमा और ये विल्म्स ट्यूमर कवर होता है। आज के टॉपिक्स में आई डोंट थिंक वी हैव वी हैव कवर्ड मोस्ट ऑफ द क्वेश्चन, साथ साथ ही आपके डाउट्स, राइट। सो ऑल द बेस्ट फॉर योर एग्जाम, विल मीट इन सम अदर सेशन। Just be confident when it comes to approaching this NEET exam, because they're going to eventually ask the same topic, same questions. Just revise your notes and be confident while attempting, right? वहाँ पे stuck मत हो जाना कि ये क्या वीडियो आ गई, ये क्या इमेज आ गई। Just read the question thoroughly and give your best shot. एंड बिकॉज टाइम बाउंड सेक्शंस हैं और एक बार आपने वो सेक्शन क्रॉस कर लिया, आप वापस नहीं जा पाओगे, तो अपने क्लॉक पे आए ज़रूर रखना। ऐसा नहीं होना चाहिए कि आपसे क्वेश्चन पढ़ने में रह गया, क्वेश्चन स्लो हो गया आप, राइट। तो एक बार स्क्रीन तो आपको सारे ही क्वेश्चंस करने हैं। जो नहीं समझ आ रहा उसको रिव्यू के लिए भी मार्क मत करो, बिकॉज दे विल काउंट इट एज एन अटेम्प्ट। इट्स बेटर, आता है करो, नहीं आता है छोड़ दो, राइट। ऑल द बेस्ट फॉर योर एग्जाम। Bell staging standards are not that important. They can probably ask standard and standard classification में कि किसके लिए यूज होती है, तो आपको पता है HI। बेल स्टेजिंग, मॉडिफाइड बेल स्टेजिंग जो है NEC की, बहुत इंपॉर्टेंट है, वो करनी है। सारनाथ इज नॉट दैट इम्पॉर्टेंट। So with that, let's end the session. All the best, have a good evening, we'll meet some other time.